Okay, good afternoon, good morning, everybody. Good morning. Thanks everybody for staying for Sunday's program, and have a lot of fun today. Hopefully you'll learn something. So we're going to talk about everything you want to know about Cushing's syndrome. And I am going to record this, so I'll put it on my website and give it to Magic Foundation for their website also. Let's move this a little bit over. Okay, so the question we're going to start with, and there's many good endocrinologists out there, but these are some of the things I hear from my patients. So the question is, do Magic Convention Cushing's patients know more than many endocrinologists? I think so. I'll show you the conventional statement and you'll give an answer. I guess we didn't get any handouts, so we don't have to worry about looking at the handouts. Is Cushing syndrome rare? Catherine, what do you think?
I don't think so.
Nope, okay. Probably not. Several papers have been published, including an article in JCM in 2003, looking at patients that had type 2 diabetes know the stigma of Cushing, of hypercortisolism. 2% of the patients are found to have Cushing's, and other 7 were being evaluated. In the clinical endocrinology in 2007, they found that 5% of diabetic patients failed to suppress the dexamethasone. And in Society Abstract in 2004, looking at 100 consecutive obese patients, 11% were found to have Cushing's. In 2004, another paper showed that out of 1,020 patients with hypertension, 11 had Cushing syndrome and 10 had subclinical Cushing syndrome, so about 2%. And I think these might have been actually low. They might have missed mild Cushing syndrome, maybe higher, so maybe Cushing syndrome is not so rare. Do patients with Cushing syndrome need to have all the signs and symptoms listed in the textbook? No? Okay. No. So the textbooks show the most severe cases. Most patients have some but not all signs and symptoms of Cushing. Patients are being diagnosed earlier, and patients with mild symptoms, they only have some of the signs and symptoms of Cushing. The common symptoms of Cushing's I see, most common that I don't think is appreciated in some of the textbooks, including, except for mine, wired at night, trouble sleeping, trouble falling asleep or staying awake, frequent awakenings, severe onset, usually of new onset. People say that the fatigue of Cushing's is worse than any other type of fatigue. Abrupt weight gain without any other causes, such as decreased activity or depression, decreased ability to exercise, menstrual irregularities, cognitive changes, the famous brain fog, decreased libido, symptoms of adrenal insufficiency, such as joint pain, can't get out of bed, nauseousness and vomiting, and depression, anxiety, and mood swings. Are all patients with Cushing's obese?
No.
Nope. Patients who really watch caloric intake and exercise, which is often hard as you get tired with Cushing's, probably do not gain much weight. If you start thin, you probably won't become obese also. All children with Cushing's are short. What do you think, guys? No? So if a child gets Cushing's before 10, most likely their growth rate will decrease. But if they start tall, they'll end up tall. Obesity leads to increased estradiol, which accelerates growth rate. Boys slow down their growth rate around 14 and girls around 12. So an older child with Cushing's is unlikely to be short. Periodic Cushing's is very rare and may not exist. True or false? False. So we published a paper in 2010 taking in hormone and metabolic research. We found that 65 of 66 patients with Cushing syndrome had at least one normal test of cortisol status, and most patients had several normal tests. The probability of having Cushing syndrome with one test was negative, was 92% for 11 p.m. salivary cortisols, 88% for 24-hour urinary-free cortisols, 86% for 24-hour 17-hydroxysteroids, and 54% for nighttime plasma cortisol. This means that there's a very high probability that you still have Cushing's even if one of these tests are normal. These results demonstrate that episodic hypercortisolism is highly prevalent in patients with Cushing syndrome, and no single test was effective in conclusively diagnosing or excluding the condition. Rather, the paradigm for diagnosis should be a careful history and physical exam, and most patients with whom mild Cushing is strongly suspected, multiple tests assessing hypercortisol should be performed on subsequent days and occasions when the patient is experiencing signs and symptoms of short-term hypercortisolism. So it's very important to do your testing when you're in a high. One normal test excludes the diagnosis of Cushing syndrome. False. Our paper on episodic Cushing syndrome showed that most patients with confirmed Cushing syndrome are episodic with one or more normal values. Thus, one normal value does not exclude Cushing's. A series of normal values does make Cushing's unlikely at the current time. I usually like to see two separate high values for Cushing's testing. You would have died from Cushing syndrome if you had it this long. False. So this is a paper my fellow wrote up in the endocrinologist in 2005. It was a patient that in 1983, this is her picture, you can see as the years go by, she looks more and more Cushionoid. In 1977, she was hospitalized with severe hypertension. She had an overnight Dex test at which her morning cortisol was sky high at 33. She saw me in 2003. She only had elevated 17-hydroxysteroid. The other tests were normal. She had a 4-millimeter pituitary tumor, so she's had it for 26 years, but her tumor was only 4 millimeters. So these can be very slow-growing, mild cases, but very symptomatic. Only severe Cushing's patients should undergo testing and treatment. False. Patients with quote-unquote mild Cushing syndrome have low quality of life. Quality of life does not correlate well with cortisol measurements, and all patients with Cushing's deserve to be diagnosed and cured. Imaging should only be performed after the diagnosis of Cushing's is made. False. Most of the patients I see have pituitary Cushing's disease. The 3 Tesla MRIs are high quality. Most pituitary tumors are seen on MRI. Patients can have incidentalomas, so a tumor doesn't make the diagnosis of Cushing's, but does give an important piece of information. A negative MRI in a patient that has a normal or mildly elevated ACTH pretty much excludes Cushing's. Patients with adrenal Cushing's have low ACTH. Patients with atopic Cushing's have high ACTH. So if you have a mildly elevated ACTH, you're probably in the pituitary range or the normal range, and having a negative MRI goes a long way against Cushing's. We just published a paper in 2007 that the literature, 50% of patients with Cushing's disease have a visible tumor on MRI, but these were older, non-dynamic, lower power MRIs. Famous paper at the NIH showed that 10% of normal patients have a pituitary adenoma. Now the 3 Tesla dynamic MRIs can pick up small tumors, and they're done much more frequently. You could have adrenal or atopic Cushing's and have a pituitary adenoma, so you have to still do the correct evaluations to make sure it's consistent with pituitary Cushing's. However, we did publish this paper in 2007 showing that a dynamic pituitary MRI has very high sensitivity and specificity and should be part of the initial workup published in Hormonal and Metabolic Research. Here we showed the sizes of the pituitary tumors. 23 of 24 patients had an MRI consistent with a pituitary lesion. You can see most of them were small, about 3 or 4 millimeters in size, but most of the patients had a positive tumor. There was only the one patient over here that didn't have the positive tumor. 50% of Cushing's disease have normal MRIs. However, in my series at least, I found that 90% of patients with Cushing's had a visible tumor MRI, and 95 have some type of abnormal MRI. Next statement is make the diagnosis of Cushing syndrome before figuring out what type. True or false? True? Okay. I would say false. I think it's helpful to get the ACTH early. Imaging is helpful to get early, and then you can sort of guide your work. Again, if somebody has a low ACTH early, you want to start looking for adrenals and do adrenal imaging. If they have a really sky-high ACTH, you want to start looking for ectopic And most patients that I see have pituitary Cushing. Therefore, getting the imaging goes a long way in helping you figure out is this possible pituitary Cushing's or not. A negative MRI in a patient with mildly elevated or normal ACTH pretty much excludes Cushing's. 70% of patients with Cushing's have Cushing's disease, 20% ectopic, adrenal, 10% ectopic. True or false? False? True? Some mix? Okay, much more Cushing's disease. My experience is that 95% of patients are pituitary. I may have some type of referral bias, but I think most patients still are. The amount of ectopics and adrenals, I think, is lower. So I have 95% pituitary, 5% adrenals, less than 1% ectopic. I have a selection bias, but the patients with pituitary are usually the hardest to distinguish from normals. The ectopics and the adrenal patients have higher cortisol and may be easier to diagnose and stay with their local endocrinologist. You need to have a UFC greater than 3 times normal to have Cushing's disease. False. In my series, only 4 of 66 patients had with confirmed Cushing's had a urinary free cortisol 3 times normal. Most of my patients had a urinary free cortisol between 1 time normal and 2 times normal. 17-hydroxysteroids are an old test and should not be performed. This paper by Mengden in 1992 showed the UFC was better able to distinguish Cushing's syndrome from normal individuals than 17-hydroxysteroids. The subjects in that study had sustained and substantial hypercortisolism. And my idea is that in high cortisol production states, the urinary free cortisol assay is better to distinguish patients with Cushing's syndrome from those without. However, at lower cortisol production rates, the 17-hydroxysteroid may be able to detect mild hypercortisolism in some patients with normal 24-hour urinary free cortisols. And this is because the urinary free cortisol measurements increase only mildly until a point of saturation of the cortisol binding globulin. Of the cortisol binding, the cortisol binding globulin is exceeded. At that time, the amount of free cortisol then does increase dramatically. So when you're measuring the urinary free cortisols at high cortisol production rates, it's definitely up higher. However, lower cortisol production rates, the 17-hydroxysteroid measurements, which are not dependent on cortisol exceeding the threshold of binding, are more likely to be linear with cortisol production. And here's a scheme that I drew hypothetical here. So here's the urinary free cortisol. As the cortisol production rate starts going up, it goes up like here. So if you're over here with somebody with pretty severe Cushing's, it's better than 17-hydroxysteroids. But the 17-hydroxysteroids will go up just a little bit at lower rates. So at a point here, the urinary free cortisol is probably going to be better than the 17-hydroxysteroids might be better than the urinary free cortisol for distinguishing the two conditions. Blood draws raise your cortisol and should be not used to assess cortisol, especially nighttime cortisol. An article in 1993 in British Journal of Clinical Practice found that serum cortisol did not rise until 4 minutes after the venipuncture. A volunteer subject awakened from sleep who had blood drawn by venipuncture. Serum cortisol is not affected by venipuncture unless multiple unsuccessful attempts have been done. So it is reasonable to get a venipuncture serum cortisol at night, and you don't have to worry about the stress of the venipuncture affecting it. A pic-line is the best way to measure cortisol. True or false? No takers? False? Okay, good. So as I show, cortisol is not raised by venipuncture. In mouse studies, cortisol was raised by having a line placed. Most important is to get a midnight cortisol. Other times during the day are not that helpful. So one of my colleagues is no longer seeing active Cushing's patients, used to get these pic-lines, and I think they were confusing and probably got too many people that looked like they had high cortisol from the pic-line that really didn't have it. You also have to correct for time zone differences. So if you're on the West Coast, you have to get it about 8 o'clock for East Coast per person if you're going to look for 11 o'clock or midnight cortisols. Morning cortisols will help for making the diagnosis of Cushing's. True or false? True. Only for sky high? Any other takers? Okay. Okay. I would say no, and we published a paper in 1995 looking at this, that the morning cortisols was basically indistinguishable. These are pretty severe Cushing's back in 1995. The morning cortisols were indistinguishable from the normals from Cushing's patients. Cushing syndrome is a disease of high cortisol at night, and therefore morning cortisols are really not that helpful. Most patients that I see at a consult yesterday that have a high morning cortisol, they're on birth control pills or oral estrogens. They raise your cortisol binding globulin, so it looks like it's high, but basically it's really not a useful test. You want to get nighttime cortisol testing or 24-hour urinary cortisols. 4 p.m. cortisols will help making the diagnosis of Cushing. False. 4 p.m. cortisols are probably a little higher in Cushing's patients compared to patients suspected of Cushing, but there's too much overlap. There's really no literature on cutoffs for this, and I would recommend only using nighttime cortisols for the measurement of Cushing. You need to do a 24-hour urine and not shorter durations to assess cortisol status, true or false? False. So the 24-hour urine-free cortisol is one of the main tests for diagnosis of Cushing's, and I say it's probably the most accepted test right now, with some recent emphasis on salivary cortisols at night. But most patients with Cushing's have high cortisol during the night. Some of them have low cortisol during the day, so the 24-hour urine-free cortisol is canceled out. I have patients collect a 10-hour sample from 10 p.m. to 8 a.m., discard the first void at 10 p.m. A value of 16 micrograms of cortisol per milligram of creatinine is consistent with Cushing syndrome. I haven't published this yet, but there is plenty of articles and literature similar to this, and it works reasonably well. Testing for Cushing's can be done at any time whether they're having symptoms or not. False. What's that? You learned the hard way, Catherine? Most patients with Cushing's, at least in my series, are episodic. You need to do testing when in a high. Record your symptoms in a diary so you can go back and see when your symptoms are high. Some of the symptoms, again, we look for: wired at night, weight gain, acne, increased anxiety, mood swings, irritability, euphoria, more energy than usual, less aches and pains, insomnia, inability to sleep, stay asleep, or fall asleep, energy levels that perk up after sunset, speed talking, the mind is going faster than your brain can process the thoughts to speak them out, water weight gain, edema, high blood pressure, you have diabetes, high blood sugars. How about this one? Patients who suppressed overnight dexamethasone do not have Cushing syndrome. False. We published in 2006 an experimental in clinical endocrinology. 14 to 17 patients with proven Cushing suppressed dexamethasone with a cortisol less than 5. The test is not that helpful for excluding Cushing syndrome. If a person has a high value after dexamethasone, this may help with diagnosis of Cushing syndrome, but those patients usually have higher other tests that can be picked up anyways. If a patient does suppress to overnight dexamethasone, adrenal or top of Cushing's is less likely though. Here's our series on the overnight dexamethasone suppression test. Some people use, the old cutoff was 5, so that's in yellow. The new cutoff is of 1.8 or so is in reddish pink. And you can see most of the patients were sort of around this 2 value, right around the sensitivity of cortisol. You only had these 3 patients that had high values. The Dex-CRH test is the gold standard for diagnosing mild Cushing syndrome. False. Dex-CRH test was developed when I was at the NIH and was only tested in also severe or sustained Cushing. Many of my patients with confirmed Cushing's had a low cortisol in the Dex-CRH test. There's a recent paper looking at the Dex-AVP test that could be a good alternative. Definitely this needs to be studied more in milder patients, but I don't think it excludes. If you have a low value in the Dex-CRH test, it doesn't exclude Cushing's. Petrosal Sinus Sampling can be used to make the diagnosis of Cushing's disease. Is that Catherine?
The diagnosis should be made first.
Right. Okay. Good. So Petrosal Sinus Sampling samples blood that drains the pituitary. An NIH study in the 90s showed that normal volunteers, patients with pseudo-Cushing, and patients with Cushing's disease had similar Petrosal Sinus Sampling results. They all had a central or peripheral gradient of ACTH, lateralization, and response to CRH. Thus, Petrosal Sinus Sampling cannot be used to distinguish between normals and those with Cushing's. It can, however, be used to distinguish between pituitary and ectopic Cushing's or pituitary and adrenal Cushing's. Those can often be done by other methods, but some patients are sort of stuck and you need to do the Petrosal Sinus Sampling. It can help with lateralization, tell you what side the tumor is on, but with high quality MRIs, you usually get that information anyways. All patients with Cushing's disease should undergo Petrosal Sinus Sampling prior to surgery. Also, no, it's usually invasive and doesn't and expensive and doesn't add that much information. Cannot be used to diagnose Cushing's. I use it with in those with confirmed Cushing's and ACTH in the range of pituitary Cushing's, but a negative MRI. Usually needs to be done when you're in a high, and since episodic patients cannot predict when they're in a high, I get a urinary free cortisol or nighttime solid cortisol the day or night before to see if they're in a high and try to interpret based on that. But it's tricky, and again, it's expensive, somewhat invasive test, and a lot of times doesn't have much information. Patients with high cortisol need extensive testing to determine the type of Cushing's. No? So most of my patients, as we discussed, are pituitary. If your morning ACTH is less than 10, it's likely adrenal Cushing's. Your morning ACTH is greater than 100, it's likely ectopic. Your morning ACTH between 20 and 100 makes pituitary is more likely. Positive MRIs can make Cushing's likely, but you can't have adrenalomas. So I usually do another test like a suppression token or a dexamethasone suppression test, which would pretty much, if you suppress it, it makes ectopic or adrenal unlikely. And I use ACTH and pituitary MRI to usually make my decision, and then Petrosal Sinus Sampling if I'm clear. Any surgeon can operate on patients with Cushing syndrome? False? The guy down the block there has a little sign out of the window now. It's crucial to go to an experienced surgeon, somebody who's done at least 200 pituitary cases and 50 Cushing's cases. Surgically, Cushing's tumors are the hardest to remove. I'm not sure if Dr. Linsky went into that a little bit yesterday, but they seem to be very, very difficult to do. They're often multi-lobulated, without much of a capsule. So I have some great pituitary surgeons I work with who trust my workup, and I would recommend using them if you can. All patients cured from Cushing syndrome should have a morning cortisol less than 4. False. The traditional approach has been that patients with Cushing's disease have sustained high cortisol, which suppresses the normal corticotropes. When the tumor is removed, the normal corticotropes are quiescent, and ACTH, hence cortisol, is low. Most of my patients are episodic. During normal cortisol production, the corticotropes continue to secrete ACTH, and you don't have this quiescent period. So most of my cured patients would have a morning cortisol between 10 and 15. I am concerned with the morning cortisol is greater than 20 or the morning ACTH is greater than 30 about a week out. I try not to do that testing right afterwards because I can get a lot of stress in surgery, but about a week out. If you have low values, it's better, but I'm not that concerned if it's not that low. All patients from Cushing syndrome will have an ACTH-staining tumor found in pathology. False. The classical approach is ACTH-staining tumors are needed to prove Cushing. My experience is most of the time cured patients have equivocal or negative pathology. Maybe the tumor's staining for ACTH was removed by the sucker and missed in pathology, or that in patients that are episodic, the tumor is not in active stage, the staining will be negative. And I'm trying to look for staining for ACTH precursors, which may be positive in patients with episodic Cushing's, but we haven't gotten too far in that. If the patient's post-op cortisol is greater than 10, cortisol replacement should be stopped. False. And I find that even the patients that have a post-op cortisol in the 10 to 15 range, they can still get adrenal insufficiency. So I usually don't stop it right away, keep them on it for a month or so, and taper them down slowly. They may experience lower cortisol later in the day that gets missed by the morning sample. It's always prudent to replace and taper if no signs of adrenal insufficiency. Cured Cushing's patients need cortisol replacement for at least a year. Okay, good. The lower the post-op cortisol, the longer patients need to stay on Cortef before tapering. Patients with post-op cortisol between 10 and 15 can usually taper off in about 3 months. I use your morning cortisol and symptoms of adrenal insufficiency as a guide. A few of my patients, especially those after second surgery, continue to have undetectable cortisol levels and need lifelong Cortef. Most patients can get off though, but usually less than a year. Cured Cushing's patients should get a cosyntropin test before stopping cortisol replacements. Yeah. Cosyntropin test works because the low ACTH levels lead to adrenal atrophy, which then leads to a blunted cosyntropin response. Cosyntropin response lags behind a morning cortisol. Patients can taper off Cortef with a blunted cosyntropin test. And I don't think it really changes my management. If a patient is tapered off Cortef and has no symptoms of adrenal insufficiency and has a normal morning cortisol, I'm not going to resume Cortef because they had a blunted cosyntropin test. Sure what happened to that one, but I think the question was, does it matter what type of Cortef you take? Yes? Okay. So dosing is crucial. So you might have a different effect between brand and generic. Cortef is the brand name, hydrocortisone is generic. When you order generic medicine, the pharmacist can substitute different suppliers without telling the patient or doctors. Core Pharma hydrocortisone is a brand of generic that patients often like. It used to be called Glade, and now it's called Core Pharma. Other brands are Greenstone, Qualitest, and Wexford. They come in 5, 10, and 20 milligram pills for the most part. You can ask for Cortef. It's quite expensive, but it's a crucial medicine. Or take a brand and stick with it. If you like it, stick with it. So I think the brand and the dosing is crucial. And Cortef and hydrogeneric are equivalent. Patients who fail pituitary surgery should get radiation. False. Pituitary radiation may take up to 5 years before leading to normal cortisol levels. Most of the patients that I deal with don't want to wait that long. Is that right? Okay. Pituitary radiation may lead to memory loss. Pituitary radiation almost always leads to hypopituitarism, especially growth hormone deficiency. A second pituitary surgery of bilateral adrenalectomy is usually preferred. Nelson syndrome following bilateral adrenalectomy is rare in my patients with slow, small growing tumors. And if needed, I haven't found any really patients with that. It can be treated with surgery if needed. Yes?
Is there a time when the radiation stops? You mentioned 5 years.
Right. Right.
To which is supposed to be.
Right.
But is there a point?
Stops working?
Yeah. Out of your body. Does it just keep destroying?
Yeah, it keeps on destroying your pituitary for up to 5 years. And 5 years, they're probably not going to do anything more. Pasireotide or Signifor is the best drug for Cushing's disease. False. Pasireotide is a recently approved drug for Cushing's disease. Almost all patients on it get diabetes. Its effect on lowering cortisol is mild and variable. It's expensive, and I find that Ketoconazole is a better choice. Ketoconazole is a dangerous drug and should only be used with severe Cushing's. False. So Ketoconazole is relatively safe, with the main side effects being increased liver tests that are reversible, that occurs usually at a dose of greater than 1,000 milligrams per day. It does interact with a lot of drugs, but these interactions can usually deal with changing the other drug. The main drugs it interacts with are psych meds and statins. So you can watch for side effects. It has a shorter half-life, so it can be given at night when cortisol is inappropriately high in Cushing's patients. I usually give 200 milligrams at 8 and 200 milligrams at 10 p.m. And occasionally patients need some morning Cortef if they go too low, 5 to 10 milligrams if needed. But if you dose it at night, and this relatively low dose of about 400 to 600, patients do quite well on it. Ketoconazole should only be used in those with confirmed Cushing's. Ketoconazole can be used diagnostically to determine which patient has symptoms are due to high cortisol. I use it in patients who I'm pretty sure but not completely sure have Cushing's, and I want them to feel better and get symptomatic relief. And I'm concerned if somebody doesn't get better on Cushing on ketoconazole, do they really have Cushing's? And I have kept patients on ketoconazole for up to 3 days without problems. I often stop it for a round of testing or if the patient develops a tumor in MRI. Ketoconazole can be given once a day in the morning. False. Cushing syndrome is a disease of high cortisol at night. Ketoconazole has a half-life of about 6 hours, so I usually give it at night in most of my patients. All patients who failed their first surgery should have a second surgery, especially right away. False. Some patients have a delayed lowering of cortisol and may be cured even if it's not that apparent initially. I usually reserve a second surgery for those patients with a visible tumor in MRI, and this is often not apparent until months after the surgery. Bilateral adrenalectomy is a dangerous procedure and should be reserved for those who still have high cortisol after radiation. False. Old data suggests that 10% of patients with bilateral adrenalectomy die. I think that's way too high. Done laparoscopically, bilateral adrenalectomy is quite safe with minimal complications. It results in an immediate and definitive cure in almost all the patients. Patients with one or more failed pituitary surgeries are good candidates for bilateral adrenalectomy. And I do like more tests confirming hypercortisolism for bilateral adrenalectomy than I do for the initial test. But if I'm convinced the person has Cushing's and we want an immediate cure, I think it's the way to go. Bilateral adrenalectomy just replaces one disease, Cushing's, for another disease, adrenal insufficiency. What's that? That's not adrenal insufficiency. So Cushing's disease gives patients the worst quality of life of any endocrine disease. Cortisol and 4NF replacement is not that difficult and it's easily monitored. Almost all my patients who had adrenalectomy are glad they did. So yes, it's technically true, but Cushing's is one of the worst diseases to have, and adrenal insufficiency is quite easy to manage. Patients with bilateral adrenalectomy just need cortisol replacement. False. Fludrocortisone and 4NF is crucial, and some patients also benefit from DHEA. The best way to monitor fludrocortisone replacement is by measuring electrolytes. False. So electrolytes change late, relatively insensitive. A renin level is the best way to monitor fludrocortisone replacement. A high renin means more fludrocortisone needed, and a low renin means less fludrocortisone needed. This can be done either sitting or standing. Catherine?
Do you do this as a
No. So the patient with the bilateral adrenalectomy, they're on their stable dose of 4NF, and then we test them to see if their dose is correct. Bilateral adrenalectomy leads to permanent cure in all Cushing's patients. False. So we have this series of patients with remnant tissue, which means regrowth of the adrenal tissue in the adrenal bed. Rest tissue means adrenal tissue growing outside of the adrenal bed. And I have, I think now, 7 patients out of maybe 60 or so who have some type of remnant or rest tissue. But in the majority of patients, the great majority, it does lead to a permanent cure, but you do have to watch out for this adrenal remnant tissue. Okay, this is one of my favorite ones. Doctor in Virginia, I think, stated this. Patients with Cushing should listen to their doctor's advice and not go on the internet. False on this one. The internet is a great source of help for patients. Support groups such as Cushing's Health and Cushing Support Research Foundation are excellent. Facebook has been taking over Cushing's and other support groups is great. I'd say the doctors state that patients shouldn't use the internet are behind the times. Okay, let's show this here.
York City. On Fifth Avenue at Trump Plaza, it's Bryant Gumbel and Gene Clayson. This is The Early Show on CBS.
This morning on Health Watch, we're looking at Cushing's disease, a rare disease that causes sufferers to gain excessive amounts of weight. Worse yet, no amount of dieting or exercise can slow the bodies of those who are suffering from ballooning out of control. National correspondent Hattie Kaufman's in Los Angeles with one woman's story. Hattie, good morning.
Good morning, Brian. Her name is Camille Kimball, and it turns out she has a treatable illness, Cushing's disease. The trouble is, most doctors know nothing about this illness. In fact, one doctor after another told Camille, go on a diet. I had been a normal weight all my life and had never been on a diet of any kind.
Camille's trim figure is evident in her wedding photos, and for her television career in Phoenix, appearance counts.
Hello, I'm Camille Kimball.
But then, one day,
I put on some jeans to go meet somebody, and I went, man, these are tight.
This is Camille today.
So your body dramatically changed in, what, a year?
Yeah, the weight gain is not her only problem.
You get sick a lot? Constantly fighting off throat infections, kidney infections, unexplained fevers. You feel stupid. You feel like you're losing IQ points by the day.
And her career?
Oh.
So she began her search for an answer.
I had what I felt was a nightmare experience trying to get a positive, correct diagnosis.
There's doctors that have experience in diseases like this, and there's doctors that don't.
And finally, Dr. Ted Friedman, an endocrinologist, made the diagnosis, Cushing's disease. While many doctors might see this patient as simply obese, a specialist looking carefully can pick out the telltale signs of Cushing's.
The bruising, stretch marks, the thinning extremities with the gain in the weight in their abdomen. There's a hump back here called a buffalo hump.
The doctor says, go on a diet, exercise.
No. You shouldn't blame the patient. You need to listen to your patient and think about it and try to do as much as you can to help the patient, not just dismiss it.
Cushing's disease is caused by a tumor of the pituitary gland. An MRI showed a small shadow on Camille's pituitary, enough to convince surgeon Harar Shahinian to operate.
We use the nostril, and we do it all through the nostril. It's sort of like looking for a needle in a haystack. You have to really go in very carefully, very meticulously,
I think 2004.
and try to find the lesion.
When the surgery is successful, the results can be dramatic.
I have had some of these patients with Cushing.
I had a lot of clips right here.
You know, they would come here, they're obese, and they come in and they have their surgery. And they come back 2 years later, and I do not recognize them.
Just one day after surgery.
I feel fantastic. Do you have any bitterness in thinking, this could have been done 3 years ago? Yeah, it's awful to have so much of your life taken away. And it didn't have to be that way. And have to fight so hard to get any kind of help. Shouldn't have to go through that.
It'll be months before Camille learns whether the surgery was successful, and maybe more than a year before she's back to her regular weight and energy level. Brian?
Hattie, what are the chances she'll make a full recovery?
Well, her doctors are optimistic, but they say sometimes, even after removing this tumor, another one can go back in a few years, so they'll have to keep watching her. And Cushing's can be fatal, so you really have to watch it.
What a terrible disease. First I've ever heard of it, I confess. All right, Hattie, thanks so very much. Appreciate it.
Sure.
Okay, so that's the question. So first, she wasn't cured. She had to go for second surgery. But here she is at her wedding. Happy ending. Looking great, doing great. 2 years later, so she got married in Seattle. What's that? No. Her husband over here, his name is David. And I did come to the wedding though in Seattle. I was on a boat. It was really nice. Very touching. Any questions or comments? No? So Phil said the drama of getting diagnosed as treated is horrible, and I think that's one of the purposes of the Magic Foundation, to try to spread the word. I think patients here are some of our emissaries to try to spread the word to other patients, using Facebook and internet and things like that. Get people to try to get to the doctors earlier, get the doctors to be a little more aggressive on the testing, and hopefully people won't have to be like in the struggle for years and years. I use Quest or LabCorp. That's basically it. The salivaries, there's a lab called ACL that does an okay job. I think LabCorp is probably better. Oh, I think the local hospitals for 24 hours will probably pick up, real high ones. If they're mildly high, hopefully they'll be enough that they'll see a specialist. If they're probably low, you might have missed being in a high. Doesn't mean that much, but it's a start.
Are like night owls.
Mm-hmm.
So the attempt adrenal on top of the game. For example, if you want a normal level of something, but their normal one is 10 or 11 a.m. The drawing is 7.
Yeah, so what was your name again? Jamie's question was, what do you do for people that are night owls? So first of all, patients with Cushing's are almost always night owls. So it makes the testing harder. I generally try, because the standards are 11 o'clock at night or 12 o'clock at night for salivaries and blood, and 8 a.m. is for morning looking at lows and recovery. I usually try to get it at that time, even if they're night owls. I try to get them to switch to the circadian rhythm a little bit if they can before they do the testing. But you have to do some of the testing, with that interpretation. Patients that are, very night owls that fall asleep at 6 in the morning or 8 in the morning, I don't know what a midnight cortisol means. It might be inappropriately normal in most people. The 24-hour urines at least have that advantage that it does able to sort of correct for whatever time of the day you're awake or not. But I think it's a challenge.
What you said about advocating for patients, I think a lot of patients are finding the Cushing's helpful.
Mm-hmm.
A lot of patients are finding Facebook groups, but until we change the minds of some of the endos,
mm-hmm.
those people still aren't going to make up.
Unless they come to see me or a few other people like me.
Right. But there are so few, and,
mm-hmm.
and I guess there are some people with fewer resources that
right. Absolutely, and I think it is changing, but I think people are recognizing Cushing's more and milder Cushing's more. I actually think the medicines are very helpful because the medicines make people think that they have an alternative. They don't have to send somebody to surgery if they're not sure. And you can, the last Endocrinology Society, they had some of these symposiums about when to use the medicines. And there was a case with sort of mild Cushing's, and everybody raised their hand, you treat them with medicines. That I think in the past they were just said you don't have it now, but now you have an option. And the company Corcept that makes Korlym has a support group that pays called NORD that pays for people to get tested for Cushing's if they can't afford it, or as long as they sort of have that diagnosis of being tested. So I think one way or another people should come get tested, and I'm happy to see them. And I think I see a somewhat large percentage of the patients with Cushing's around the country, and try to get, still just one way or another, they got to get seen. And we, endocrinologists like me and patients, and got to try to encourage the doctors to really, what's best for the patient,
One of the questions you asked initially was, is Cushing's rare?
Mm-hmm.
And I say that, no, it's not rare. It's rare that doctors diagnose it.
Right.
And I look more at the first doctor, your 50s,
mm-hmm.
because they're the ones that see you all the time.
Yeah.
And yes, while yes, it's true that there are some endos out there that don't have a clue what Cushing's is about, but it's the initial doctors that you see. I think you really have to see the message. And once you've been diagnosed as a Cushing, you know the symptoms. So look at a person you can tell. a lot of times, just looking at it.
Yeah, yes and no. Some of the symptoms are pretty non-specific and signs are non-specific. And, people come to my office the first time and say, Doc, what do you think? I have Cushing's. I say, I don't know, I got to do tests. If I could predict people, then yes, I wouldn't have to do tests, but not that good yet. And I have a lot of experience with Cushing, so I think your average PCP really doesn't. They should at least refer them to an endo probably. But the patient has to, in those cases, have to tell the doctor sometimes what tests to do and how to do it and send me to a specialist. And I think it's hard. It is still a relatively rare disease, and obesity and fatigue and diabetes might be more common, so it requires some expertise.
In my case, I was undiagnosed.
Yeah.
And I got to the point where I could barely walk to the bathroom without stopping.
Horrible story. Yeah, sorry to hear that.
And I know one day I was at work and I came back to my desk and I said, God, you've got to help me with this. Because I can't do it by myself anymore. I was almost 375 pounds.
Yeah.
And I went to my doctor and I said, what happened was I seen a commercial on TV about cortisol, how to make belly fat for all my weight.
Yeah.
So I went to my physician and I said, can you test my cortisol? They laughed at me. And they said, you got to go to an endo. So I went to an endo, and she even questioned. She thought maybe I had fatty liver disease. But she saw crushed anyway. So I had 3 times the amount of cortisol. So my journey started there with Cushing's. But for so many years, it was always you're fat, and you got to exercise more and eat less.
Yep. I think everybody in the room who went to the story probably told that at one stage or another.
Yeah.
Over here.
Could you share what
So the question is about familial Cushing's. I have a couple families that seem to have it. There is a doctor in England, Dr. Corbinitz, who is doing some testing on it. There's a gene that she's found called AIP that seems to be familial pituitary problems. None of my patients that she's tested have that so far. She's tested 2 families, and I'm going to send her my 3rd family. But there is something, obviously, that once one person gets it, not the next person. It must be in your genes, and you pass those genes down to the next person. As Phil knows, there's a pocket in central New Jersey that has a pocket of Cushing's also. I must have 5 or 6 patients from 20-mile radius swamps of Jersey, as we say. There was some environmental also that, again, your kids are in the same environment as you, that also probably predisposes to. So I think either the prudent thing is if your child is starting to look like having Cushing's, get them tested. I would say that's not a reason not to have children, for example, but if they do, test it.
I was wondering how many atopic patients you diagnosed?
Very little, 1 or 2, but I think most of them get picked up by the local doctors are more severe. I think it's much less common than pituitary adrenal. So, if I think they have a topic, I'll test until I find it or take out their adrenals. When I was at the NIH, I had a lot of atopic patients, and we based it basically on the Petrosal Sinus Sampling. It was a negative Petrosal Sinus Sampling. We assumed they had a topic. And I think sometimes the Petrosal Sinus Sampling was wrong, and they probably had pituitary. But I'll try to find it. I think that's hard to say. I mean, when we were at the NIH, it was sort of built in. We had a sort of a system that, they were labeled as pituitary if they had a central or peripheral gradient. So almost every, by definition, sort of everybody went down that path. But I think some of them were wrong on. So it's probably 95% or 90%. The caveat is you have to test when you're hypercortisolemic. If you don't test when you're hypercortisolemic and you have a topic, you look like you have pituitary. So I think that could be some of the problem. Say it again?
The gallium dose or neural endocrinologist. They're doing studies on NIH.
Yeah, a little bit. Yeah, just a little bit. Bill?
So I have a question about efficiency. People like myself and others, we consider ourselves really
right. You are zero. Yeah.
The difference is between, say, someone who has LA, someone who has a pituitary nation, activation response. Anecdotally, from the Facebook groups that I've talked to, it seems like people that have PLA require less dosing than people with AI and have an easier time regulating.
I don't think so. I think adrenal patients have a harder time because they're missing both their 4NF and their cortisol, while the pituitary ones are just missing cortisol. Second of all, the pituitary hormones such as growth hormone and thyroid hormone cause you to catabolize cortisol less. So a person in theory can have really not make complete panic a bit, and as long as they don't start taking thyroid or growth hormone, their cortisol stays around a long time. Doesn't get catabolized, they do okay. So for those two reasons in general, I think patients with pituitary adrenal insufficiency do better than those with adrenal, but I think all patients do pretty well. And I think, most patients are like you, they're doing fine, and monitor them with a renin level and get them a good dose of hydrocortisone.
So the relationship to that question, I take about 20 milligrams.
Right.
And I know some others who take less than that.
Yeah.
And yet people that have their adrenal glands still, but are adequate, are taking 35.
No, I don't think so. They should be taking the same or less. Patients with Addison's disease, it's very similar to BLA patients. Adrenals aren't working. Patients with pituitary hypoadrenalism usually do at least as well. But it also may reflect, my patients, I try to put on less than the other doctors also. They affect your metabolism of cortisol. It's usually your serum levels are okay or low, but if you're growth hormone deficient and thyroid deficient, hypothyroid, you convert your cortisone to cortisol, and that little cortisol you have stays around much longer. When you start treating it with thyroid and growth hormone, it breaks down the cortisol, so that little cortisol you have is all gone, and you can throw you into adrenal crisis. We'll talk about that in the pituitary replacement lecture a little bit also. Couple more minutes for Cushing's questions. So the question is about milk thistle to lower cortisol. I haven't used it much. I think the best supplement to lower cortisol is phosphatidylserine. Called phosphatidylserine. That's all. PHOSPHOTIDYL serine, SERINE. I usually have people take 300 milligrams before they go to bed. So sinus infections are a stress to the body, and your body reacts to that by increasing your cortisol. Patients that have no adrenals, they can't increase their cortisol, so they should probably take more, but they may have more trouble fighting off a sinus infection, for example. If you're going to be testing, you probably don't want to test when you have a sinus infection. It doesn't look like you're in a high when you're not. One more?
Yeah. What was the recommended?
Probably take all your adrenals. Go ahead.
Have you found that
So the question is about cysts in the nasal passage, the cause of Cushing's. I think it's extremely rare. I think Mr. Caldwell probably has one, but it probably might have been a remnant from a surgery, not from being born with it. Most cases I see are from the pituitary, but if the surgeon takes out the pituitary and leaves some of the cells behind as he's going down, I think that's what happened to you maybe. Go ahead. Anyone else questions? Sure, I understand your questions particularly. So patients with pituitary problems have low TSH. Patients with thyroid problems have a high TSH. So if you have both pituitary and a thyroid problem, your TSH may be both should be canceled out and be relatively normal. But your free T4 will be low for both conditions. Cushing had high cortisol can maybe in theory at least, decrease the TPO antibody, treat the autoimmune conditions, and that could help with your thyroid problems, for example. Okay, shall we go on to the second talk? Sure, go ahead. Yeah, okay. I'm recording it, but yeah.